The humble wedge gives us so many benefits when it comes to Class II. Like going back to basics, you put a wedge in for your Class II and it ensures that the matrix is right up against that cavity margin. So wedging is important. The other benefit, of course, that it gives you some separation. And this helps to accommodate for the actual width of the matrix band so that once you finish your restoration, you remove the wedge and hopefully the teeth will rebound and you'll have a contact. Another benefit of wedges is actually suppressing or depressing that papilla. It allows you to manage those deeper cavities with much more ease. So as you can see, I'm a fan of wedging, and I even invested in all sorts of different types of wedges and those low profile diamond wedges for those trickier and deeper scenarios. So why is this episode on doing your Class II restorations without a wedge? Isn't that a little bit crazy? Hello Protrusive, I'm Jazz Galati and welcome back to your favorite dental podcast. So let me tell you, it was like a paradigm shift. It was a big shift in my thinking when I started to use this technique without a wedge, because the wedge has so many benefits, but how many times have you introduced the wedge and seen that your matrix band has completely now moved away from your contact? You have an open contact now. And sometimes, a bit like the ring, the wedge can distort your matrix. So if there is a way to do good quality Class II restorations and get a contact and get a seal without needing to use a wedge, then that is worth exploring, and that's exactly what we're doing today. My guest, Dr. Sunny Sadana, is a major fan of the Greater Curve matrix band. He's a distributor in the UK. Now, many of you in the States watching, listening to this are already very familiar with the Greater Curve matrix band. It's something that I discovered probably about 18 months ago through Sunny, and now about 70% of the cases I do are with a Greater Curve matrix band. I still use sectionals, and we'll come on to that in the meat of the podcast, because Sunny doesn't use any sectionals at all. Whereas I think there's still a place for sectionals. For your smaller cavities, the nice contour that you get is great. But for those big behemoth amalgam replacements, those MODs, those subgingival areas, I went through a phase of trying to make a sectional work. Like the sectional just wasn't going to work, but I was desperate to make the sectional work. So in my aging population of patients I see, the Greater Curve has been absolutely brilliant. And so two shocking things you must know about the Greater Curve. Maybe, should I give it a spoiler? Should I not? I'll do a little bit of a spoiler. So if you follow the protocols, you don't need to use a wedge. So I think that is well worth a listen. So hang with us to find out how that actually works. How can you use a matrix without a wedge? Don't you lose the benefits of the seal and the separation, all that kind of stuff? And secondly, something called the contact opening technique, which I think will blow your mind. It'll feel like dirty. It'll feel like the first time you're learning IPR. I think, I don't want to do this. This feels wrong. But actually, this contact opening technique has been absolutely brilliant in the clever way to support a wedgeless technique. The protrusive dental pearl I have for you today is actually about wedging in a way. It's probably a recycled one from one of the older episodes, but the value of pre-wedging. Like here I am saying that wedges are important, and then I told you that now I'm not even using a wedge in many scenarios because I'm using the Greater Curve protocols, but I'm still doing pre-wedging. Pre-wedging is like, for example, you get a wooden wedge, and after you've numbed up the patient, you're going to put the wedge through, and you want to get it really through. You're going to build some pressure, right? And sometimes when I'm breaking contact, I like to use like a fender wedge or one of those plastic wedges with that metal shield, right? To make sure you don't damage the adjacent tooth. So we don't want iatrogenic damage. Either way, I've got some sort of wedge in there. And the benefits of pre-wedging are brilliant. They really help you out in making your restoration, your Class II, which are tricky things. It makes it easier. For those of you who already pre-wedge, you know the benefits too well. And you can't imagine doing a restoration without pre-wedging first. But if you're not yet converted to pre-wedging, give it a go. Get that wedge in before you start to remove the caries or the old amalgam. And you'll see that it gives you better access to subgingival areas. Perhaps it's just slightly subgingival. But because you introduced a wedge and it's been there for a while already, by the time you take out the wedge to do your matricing, the papilla has now already been suppressed. You don't need to remove the papilla. You don't need a papillectomy because the wedge just suppressed your papilla. So whilst we do talk about not using a wedge, I'm still a big believer and a fan of pre-wedging. Hope you enjoyed this episode, and just to let you know, some aspects of this episode are exclusively on protrusive guidance. Why? Because this is a public forum, and some of the things we discuss when it came to communication, fee setting, what is a fair price to charge patients. If patients kind of come across stuff, it's not really the right platform for them. It's like strictly dentist talk. So the best way to consume this episode would be on Protrusive Guidance. It's our free app. There are also paid plans for CPD and my masterclasses, but essentially the community is free and you can access the behind the scenes, the hidden talk that I'm telling you about fully on Protrusive Guidance. But I hope you enjoy this talk about the wedgeless technique and something called the contact opening technique, and I'll catch you in the outro. Dr. Sunny Sadana, welcome again to the Protrusive podcast. This time actually on the podcast. Before we went so visual, we had these beautiful visuals. And if anyone hasn't seen this episode I did with Sunny, just walking through like all the mainstream matrices there are, the pros and cons, lovely little table you made. That is an absolute peach of content that's on YouTube. But I want to make something that's widespread, spread this knowledge across the world through Spotify, Apple, and other means. How you doing, buddy?
Yeah, I'm good, Jazz, man. Nice to see you as always.
It's been great to see your journey over the years. I briefly met you when Pei organized this thing with Enlighten, like briefly across the room. And Pei said to me, you know what, you need to meet Sunny, right? And then when you spoke, I was like, wait, who's speaking? And I saw, so you have the most Cockney, you sound the most Cockney person I know, right? So that was quite pleasant. It's been great to know you, your ethos and everything. So Sunny, I know you, the community knows you. For those listening, watching, haven't come across your work before, tell us about you.
So I am a practicing dentist. I mainly do restorative, and that's mainly on a referral basis. I'm also the head trainer at II Composite, so the II Composite course, which stands for Direct Restorative Excellence, not Dr. Dre. And yeah, composite's my thing, and yeah, live and breathe it, and particularly using this matrix system called the Greater Curve matrix system, which absolutely changed the game for me and for many other delegates now. That's pretty much me in a nutshell. Clinically, at least.
Let's talk about that because you influenced me a lot with this matrix as well. So the Greater Curve matrix has always been on my radar. I've been on Dental Town before. I have American friends, and therefore, we know about the Greater Curve matrix. And then essentially, you got the license. Is that how it works? You got the license to distribute it and teach on it in the UK. Is that how it works?
Yeah, pretty much that. But I mean, the way that it actually all came about was after sort of 8 years of trial and error, should I say. I didn't have the smoothest of dental journeys. Became quite depressed with the whole thing. I found dentistry quite difficult. NHS practice to NHS practice. Then I went to a squat private practice and realised I wasn't, that actually private dentistry wasn't the saving grace. It was actually, it comes down to your skills and your abilities with patients and how you communicate with them and being able to adjust with them and all the rest of it. And so I did what everybody does, right? Taking your advice. I did a bunch of courses, right? All the big names, did spend a lot of time trying to learn from some greats. Hopefully some of their magic will rub off on me. But sadly, it just didn't transpire that way. So after spending quite a lot of money, having a young family as well, moving into this squat private practice with very few patients, you can imagine the pressure was on. And so the fact that it wasn't really materialising I don't want to tarnish it by talking about the money, but I mean, look, we've got to live. And it just didn't really turn up. I was kind of at my wit's end. Tried to actually leave dentistry for a while. If anyone's on the Dentist Who Invests Facebook group, they'll probably see my Bitcoin analysis. And let's just say that didn't really work out as well as I hoped. But, I've been given a third chance this time, so we'll see how this cycle goes. But nonetheless...
Hashtag when Lambo.
Yeah, indeed.
Just want to get that in there.
Indeed. Lambo's a bit cheesy, but I do love the Lamborghini Auris. The truck. It's actually quite cool. Nonetheless, returned to sort of dentistry, really determined to make a good go of it. And so I just really doubled down on everything. And I spent a lot of time listening to American podcasts, Howard Fran's podcast in particular. So really influenced by him and just the pragmatic way that Americans thought. And in my mind, I thought that, NHS really bogs people down and the conversations are, about UDAs and this. And I just felt like I was really kind of shackled by that mindset. So I really went into the American side of education and and that's when I came across Dental Town. And then I was always into composite. And then I came across Greater Curve System. And at the time, there was like 17,000 posts about this matrix. And I'm looking at it thinking, hold on, there's no wedge here. There's no ring. Yeah, this guy's getting a great contact. It just looked ridiculously simple. That how
It's like voodoo. When you first come across it, I'm glad we're talking about it already because I was going to ask you about the whole journey of getting Greater Curve to the UK because previously lots of dentists, as they now obviously they buy from you, but previously they'd go straight to America and try and bypass customs, etc.
Sure.
to get this kind of stuff over here, right? And so it's great that you did that, and it's nice to know that that was your journey to getting it. But you're right, the biggest shock factor for me, because this episode I want to talk about all the different types of matrices, I guess, but the biggest shock factor for me, which I was skeptical about, was the whole thing about wedgeless, right? And then I'm not going to say the next point because it's too early in the podcast to give two shockers to everyone. Let's just start with one, okay? You don't need a wedge when using this matrix, which was like we could totally discuss that and then how that works out, why that can be advantageous in a moment. But please carry on. You were also blown away, like I was eventually, about the whole no wedge technique. What else did you find compelling?
I mean, there's lots of, I suppose, rubber dam's like a big, massive topic, right? Whether people are very, people die on that hill, right? But there are downsides to rubber dam as well. Sometimes it doesn't work as well. It's technique sensitive. Some patients don't tolerate it nonetheless. So You know, it's almost like you use rubber dam, you get a good bonded restoration. If you don't, you don't. But we've all got restorations where we didn't use rubber dam and it worked out quite well. And actually the pivotal thing was the moisture control, right? It's the isolation. And the thing that was really compelling to me was the seal from this matrix alone. You can actually get standalone isolation. So, you know, instead of just not using rubber dam, you could use a split dam and put greater curve on. And, yeah, pretty much you've tackled all the problems right at the local level, as well as controlling for humidity and all the other benefits that we have from rubber dam, including, you know, protecting the airway and all that good stuff. So anyway, you see lots of shots like that. I was like, I'm not sure I could post that on a UK Facebook group without getting shot down. But here we are, you know, with lots of dentists.
By the rubber dam police.
Exactly. But, you know, my point is that use rubber dam. I've got nothing against it, right? But there are times where you can't. And, you know, example being, and I know we'll get onto that as well, DME, right? You know, the funniest part about rubber dam is at the deep margins, when you really need it to work, it just doesn't. We have to split it. And so, you know, that's where greater curve really shines. And we'll talk about that, the whole subgingival. You know, how I'm not a specialist, I don't have a diploma, but I'm able to tackle pretty much anything that comes across, you know, my table, anything that's referred to me, I can deal with it, right? And so for me, that's magical. You know, the ability to serve patients to that level is magical. So back to, go on.
With the seal that you mentioned, just for any of the younger colleague students, the seal we mean is that gingival seal, i.e., you know, the very deepest, darkest bit of your cavity, right? The bit that you know, the seal is the deal in that area. And you're right, you know, I was quite impressed with the divergence that you get from the greater curve, hence the name, you know, greater curve, I guess. And then the way it tightens at that base. And the ability to get the seal where, you know how sometimes you wash a cavity out with 3-in-1, there's the spray, right? And then you dry it, but then there's still liquid residue, there's still water residue, fluid, you know, at the base. A lot of time, not every time, right? But a lot of times, I'm blowing air and it's like super dry. I've never been able to achieve that with any circumferential matrix. But I guess let's just start with that then. 2024, you are unique. And I know you are unique, but you're spreading this methodology and this way of thinking whereby you are looking for a pragmatic solution. And obviously, look, let's admit, you're going to be biased. This is your baby in the UK now, right? You're going to be biased because this is your matrix. And recently, I know I did some episodes about BioClear matrices and stuff. So I'm not here to say that any one matrix is the best, because in my hands, I'm using your matrix, the greater curve, not your, but you know what I mean, the greater curve one, 70%. That's a lot, right?
Sure.
That, I mean, you asked me 2 years ago, I didn't own the greater curve matrix plan, so obviously it was zero. So from 0 to 70% of all my restorations, okay, are now greater curve. Number one reason being is my patient base is 60 plus, and I'm most of the time replacing behemoth amalgams, okay, which is subgingival, right? And they're pretty much, okay, you know what, we can probably go indirect here and go ceramic, which I do a lot of as well, or we can go a large restoration, and therefore my matrix band of choice is the greater curve. I still use sectionals because I just find that, and this is a real important point, is because I went through a phase, Sunny, of using sectionals like for everything. Like no matter what the cavity ended up looking like, in my mind, I was like, if I'm not using a sectional, I am a deficient dentist. I am cutting too many corners. I am not being anatomical, whatever that means, right? So therefore, I fell into this trap of Emax trap as well. But at one stage, I know Zach went through as well, everything was an Emax onlay at one stage, right? Like I went through this phase. So everything was an Emax onlay once upon a time. And I know people listening and watching are going to resonate with this. Everything was a sectional matrix once upon a time. And then you realize, you know what? You got to use the best tools at your disposal, and you got to adapt it for what you have in front of you. And sectionals, when it got too big, when it got to medium to large, yes, it can be done, but it's a lot of effort for the reward, which can be unpredictable. That's what I found. What was your experience with sectionals, you know, as you developed into your enjoyment and fulfillment of composites?
Well, I mean, my experience with sectionals was never that good, you know. In fact, learning from some really great dentists who are doing this magical stuff, you know, and then I'm getting back to the surgery after doing 10 hands-on days, and then I still can't get a sectional to work, right? And then I thought, shit, is this just me, or is there, are there other people that feel this way? And that's obviously what spurred me to go and have a look on these American forums, and also just for the American approach in terms of just, the business of dentistry, right? So again, really influenced by Howard Farran's book, Uncomplicate Dentistry, I believe it's called. But it's a business book about dentistry, and it's one of those books I listen to every year just to really center myself when it comes to all things business and dentistry. Nonetheless, on that forum, I found the system. I ordered it 2018. I started using it for 2 years. I just gave up on sectionals because it made that much of a difference to me immediately. I just didn't need them anymore. However, I didn't know a single soul that was using greater curves. So here I was trialing and erroring away for 2 years by myself. And, of course...
Well, you had the forum though, right? You were on the forum, I was picking up tips and sharing. And
I was a lurker, as 90% of people are, right? Social media is quite a new thing to me, right? It wouldn't look that way when people look at my social media, but it's quite a new thing to me. And so prior to that, just a lurker really, I was more into playing football really than being too much online. So that was a bit of a shift. So I didn't really ask any questions there, either. And then the stars really aligned in 2021. I actually heard Dr. Brown, the inventor of the Great Curve system, right? And this is a dentist in his 70s, 40 years of experience, talking absolute truth with how it's run. And I was just immediately drawn to this guy. I thought, wow, this guy's pragmatic, super pragmatic. In fact, he says something super outlandish. He says on the podcast, I do most of my dentistry without a rubber dam. And, nobody can say that. And it's almost like, contentious. It's like, oh my God, what a bad person. But this guy's got amazing recalls, 10 years plus of ridiculous things, He built up an Apple Core style incisor or lateral, can't remember the one that, and then he used that with ribbon to replace a direct ribbon bridge to replace the central. And that's going, the last he saw it was 5 years strong. And so it just mind-boggled me what was possible. And I knew things were possible, that I didn't think was beforehand. For example, training with Sabir Banerjee, you'd see his recalls 20 years old when the composite was rubbish and there was no air abrasion. And, so I just knew there was a world of possibility, and I just never had it. And then I got to taste it with this system. And then anyway, once I heard Denny on that podcast, I emailed him and he said to me, let's jump on a Zoom. So we did. We hit it off. We had some real stuff in common. He was interesting thing about him is he was a Vietnam War veteran before he became a dentist. So I actually served in a war. It's pretty gnarly stuff, right? But very, very down to earth, humble guy. And nowhere near that level of service, but I was an Army reservist for 5 years. So we just had this kind of common ground and understanding. And for both of us, it's pretty much like, what's the most effective way to do anything with the least amount of steps, right? You want to be the most direct, most effective. You don't want to go around the long-winded route for no reason unless it had a strategic benefit. So we just kind of really aligned in that way. So then he said to me, start bringing me your cases. So I did. And then with that, that was pretty much the beginning of this sort of mentorship from 4,000 miles away. And so we would do these calls very routinely. I bring my cases. He basically retired after COVID as well. So yeah, it was just really a kind of like a natural fit for us to kind of, we became friends from this point. And so I continued in that capacity for probably about 9 months, and my dentistry got so strong.
Do you mind me asking, Sunny, if this was was it a paid arrangement, or was this guy from across the Atlantic just being super nice to you and just like teaching you the ropes and giving you his time?
Exactly that. So
wow,
what a top.
That's rare.
Yeah, what a top guy, right? What a top guy. So I'd like to think it was something to do with my charming self too. But but no, I mean, he's a great guy, right? So lots to be thankful for in that regard, giving me the time. And so, people sometimes look at it and go, it's just a matrix. Why do I need to listen? There's so much nuance to this thing. You name any restorative problem. You think of something that is tedious, difficult. Once you've been trained, this thing just solves it, right? Black triangle, diastema, extreme subgingival class 5s, direct composite onlays, with the way that we're doing it is just so slick that the time it takes is just minimal, right? And no patient wants to be in your chair longer than necessary anyway. So patients love it. You're giving them a great result. And we'll get onto, how the market values these kinds of treatments, because sometimes, composites are kind of seen like a bit of a tedious thing that we have to do, but actually very rewarding for patient and dentist for many reasons. Anyway, nonetheless, from that mentorship, my dentistry just really improved, so much so that 9 months after that, quite a bold move, I left associate dentistry to set up a private referral service. And so the beginning arrangement was pretty much I was visiting people's surgeries and doing cases that, they were going to extract these teeth pretty much. And so they'd send them to me, I'd do it, and then, that was how that started.
How do you even begin to create a service like that? I mean, how do you even, I imagine you just have to contact all your colleagues that be like, listen, this is the kind of dentistry that I think I've got an interest in, that I really enjoy, and these are the problems that you guys probably don't want to solve, and I'm here to solve them and take them off your hand. Was it just that, and just letting them know that you were out there and ready?
Life is like serendipitous sometimes, isn't it? It's just so funny how these things unfold. But the initial arrangement, funnily enough, wasn't a restorative service. It was me and a friend, and we set up an endo referral service as a non-endodontist, which is crazy now when I think about it, because I did a few courses.
What?
Yeah, I know. Don't even get me started on that. In fact, I remember the first clinic was so crazy. Now, really nice married couple that own the surgery. One's a dentist, one's not. Really lovely people. Got all the time in the world for them. And that's how it unfolded. It was so crazy that my friend's mum was seeing the lady dentist as a patient, and then she had said, we'd start this practice, we're looking for dentists. She said, my son's a dentist. And so that's how we got in touch. And so I went for this interview at the time, right? Wanting to move on from where I was. And it just turned out that it wasn't going to work out for me to be an associate in that respect. Yeah, like I wasn't doing NHS at the time and all the rest of it. And then it just struck me that actually they were like referring some stuff out of their surgery. And I just said to them, look, why don't you send those endos to me? I'll do them in-house. My friend will come and assist. And then, you keep the patient, you do the crown, we'll split the income. And I remember the first session we did, I think we started like 1 o'clock in the afternoon and we finished like 11:30 at night. And I found an MB2 at that point, and it was just awful. And the practice owner, my non-dentist friend, comes into the room and he looks at me and he goes, oh, we had a cracking day, didn't we, lads? And I was like, yeah, cracking, absolutely cracking, you know? And I was just like, what have I done? So that was the birth of the service. And then because actually the thing I was best at was these really gnarly teeth that needed endo, I could fix them up really quickly though. You know, I could do a pre-endo build-up so quickly. And they're just like a really slick little clinical tidbit of how that works. Just, you know, you've got these really broken tooth, guy's got irreversible pulpitis or something, and you need to be able to get a clamp on. And actually, sometimes you can't get a clamp on a really broken tooth like that. So you could put greater curve on there. You can add just a little bit of EDTA, right? So no hypochlorite, and you could do your coronal flare. Yeah, you know, you could just do your coronal flare, make that space, put your GP in there, and then etch and bond around it and build up your wall. And so you're maintaining that straight line access. Nothing's going down the canal. And actually, it's pretty easy to do the endo from there and then fill the center, right? And, you know, a lot of these guys are going to go for indirect. But I know I've done that DME or, you know, the wall or the actual core, whatever you want to call it. I know I've done that really, really well.
The perimetral build-up is something that Pasquale Venuti says. You know what? I was actually thinking of Pasquale earlier when you're talking about it, because one of the issues that Pasquale is very good at pointing out is when we are doing, for example, class 5s, and you see some dentists, right? They've got rubber dam on. They're doing these class 5s, right? And you can imagine now, you've got like the most distal molar clamp, okay? You've got the most mesial clamp, because why not, right? And then for the class 5s, you've got like 2 Brinkers B4, right? And so in 2017, I was in Sydney or Melbourne, right? And I was there. Pasquale was lecturing with Lincoln, and he described it as the circus. The circus. Yeah. So it's a circus, right? And he was like, I love this. Right, this he's right. This is the circus, right? Because he just said, sod all this, just whack some PTFE in the sulcus, you can be fine. And that for me was like paradigm shift. Like, yeah, he's right. Well, why are we juggling this and everything's like falling out and collapsing? And it's not. You can't do it on Stoke on Tuesday night. Right? You can't do it in your practice. Only the elite can do it. So that was the first taste of that. And everything you're saying is very much echoing that thing about making things easier, breaking things down. Why not just because it's not sexy doesn't mean you can't just use one clamp, which is actually superior in many ways, to get that seal in the trickiest of cases.
I mean, interestingly too, I mean, we're talking about that, but I mean, for me, hands down, I am biased, everybody knows it, but I mean, when it comes to class 5s, you can give me some really, really difficult ones, and I'm going to get that done with a greater curve that, you know, it is so straightforward. And then any worries that you have.
Dude, you do everything with a greater curve. I just want to emphasize
that's
that.
That's right.
Sunny will do a class 1 with a greater curve. No, I'm just kidding.
You laugh at that, but like if I've got an upper 8 and it's like really difficult to keep it dry, I put the greater curve on and I do it. So yeah.
That's true. Okay, fine. Right, that's actually true. So there we are. You name a class, you name any restorative scenario, and you got your trusty greater curve, which it takes. It's a bit of a learning curve, and that's why you run course on it and stuff. It's a learning curve, but having used it now for 15 months now, 18 months, I don't know, when you introduced me to it, I have to say, like I said, 70% is a big deal. I think if I had a younger population, I'd probably use it less. However, having said that, if I had a younger population of patients, then perhaps post-orthodontic black triangles might be more of an issue. And I've seen you and your colleagues do so many great black triangle closure cases as well, especially using that brass one, for example, or the U-band. You got different like matrix designs. But fundamentally, the thing, let's talk about the 2 most shocking things about this system. So just to recap, guys, matrices nowadays, I'm using greater curve 70% of the time, circumferential matrix, which I never thought I'd be saying. Like, if you asked me 3 years ago, I would never have said that I'd be using a circumferential. But it is what it is. I'm man enough to say that if something good comes along, I'm just going to accept it. I'm just going to be like, you know what, fine. I poo-poo what I was doing before, and this is now better. I accept it. Let's move on. And so that's the situation now. I'm using a Paladin. I'm using Tor VM in those smaller cases. I'm still using rings in those smaller cases. But that's about 30% of my work. Anteriorly, class 3s, it's massive bugbear for me. Honestly, I hate class 3s, especially through and through class 3s, right? Yeah. Through and through class 3s, I find very fiddly. I've done the whole thing about the mylar strip and the wedge, and it gets very fiddly. And then when you told me to use the greater curve for the class 3, I was very, again, skeptical. But it went really well, the seal. And so I've enjoyed a few cases doing it that way as well. But like I said, you use it for everything. And so you can find your perfect ground. And if you like using sectionals, still use sectionals. But when you have that case that is super subgingival and is tricky, don't try and put a square into a round peg, right? Don't do that. Just use a system that's actually built for that purpose. Because part of the beauty is wedge-less. So tell us, why is a wedge-less scenario advantageous in those deep subgingival cases?
Maybe not just for subgingival, just in general, Well, actually, let's address that point head on. First of all, when it's super subgingival, to get that seal, you need to put a wedge really subgingivally, and often that is tricky, right? Then, sometimes I see dentists who've got all these different types of wedges and they're still struggling. And then the tray will have 5 wedges, 4 sectionals that they've gone through trying, No, playing to see which one fits. Whereas
customizing the wedge yourself with the burr or the wooden one, and then diamond wedges are great. Diamond wedges are great, but sometimes even then you're not going to be able to get that low profile enough.
Totally, and there's variability in the patient, right? Some people have these thick, soft tissue. That's really hard to put anything down there. So nonetheless, we've just got all these variables to deal with. Whereas not having to worry about a wedge just takes that variable away. So I do offer like a free CPD sessions on our website, right? People can just book it, one-on-one for their practice, whoever. Just so they can actually see these scenarios. And the first few subgingival scenarios I show are just plug and play solution. It pretty much is you seat the Greta curve, you tighten it in place, and the seal's there. And then there are more extreme examples where I'm talking like almost crestal, really, really subgingival. We're able to do that. But then, of course, there's a bit of a technique. We call it a cervical relief technique. You've posted it in Protrusive guidance where you adjust the bottom of the band. But those are, I don't commonly do that. But there's a nice, clear sort of progressive framework that if this, then that, So then when it comes to subgingivals, there are like only 4 things that we do. And we just go in that order until you get to get the seal. And if you can't get a seal with Greta curve, it's quite unlikely, it's going to involve crown lengthening at that stage. It's going to need something beyond direct resto. Back to your question as well with wedges. So number one, with subgingivals, quite difficult to even just get a wedge to do its job. That's number one. Number 2 is getting a contact when it's really, just in general, getting a contact can be difficult sometimes. And then when you've got wide spaces, the more subgingival it goes, the wider this space becomes as well, just by nature of the lesion. And so again, having to try to wedge there to get some separation to compensate for the thickness of the matrix in hopes that it comes back, touches, and gives you a contact can sometimes be very hit and miss. That can be hit and miss for people when they're doing quadrants. I love a good quadrant. I think it's one of the most underrated things in dentistry, right? You don't need to market for it. There's no lab bill, it's not Invisalign, there's no implant complications, your indemnity doesn't go up, but patients all need composite, right? And so when you can do a quadrant really well, it's pretty staggering. Like, so just delegates, forget me, people see my cases, they see my efficiency, that's cool. But then a delegate can come and do 6 weeks with us, and then they can turn around and say, I'm doing these quadrants in 1.5 hours, and, charging average composite costs.
Well, I want to talk about this specifically because I told you on the phone that a lot of patients have started to watch this YouTube channel. If you're a patient listening to me on Spotify, God help you. If you're a patient on YouTube right now, get out of here. It's not for you. It's for dentists, okay? Like, just leave, okay? And so some of these parts of this conversation, which are super cool, super important, communication kind of stuff, I'm going to reserve for Protrusive guidance. So if you guys are not on Protrusive guidance yet, protrusive.app, come on there. There's a space there to discuss greater curve cases and that kind of stuff as well, which is pretty cool. But I want you to come to there to come to this extra bit that Sunny's going to talk about where it comes to efficiency and workflow and make sure you're cost effective for your clinic as well. But we'll come to that. But yeah, the whole wedge thing, like you said, you put the wedge in and then the contact opens up. Mm-hmm. You've lost your contact.
Yeah, exactly. And 2 situations really come to mind as well. Is that sometimes where you got like first of all, I've just got 2 really distinct things that I know we address quite well as well in my mind. One is like, when you have like a complex cavity, where it's just not perfectly spherical anymore, and you put on like, let's say a pro matrix, this thing collapses in and you get gapping one side, it just kind of contorts, right? And so that's one very common issue. Then the other one is like, in a similar way, where you have a wide space, you put this matrix on, you've already got a space, and now you're going to wedge, and it makes the space worse. And so now you're playing gymnastics, trying to do stuff with this matrix, trying to hold it over and all the rest of it, And it's just super difficult. And that is, again, I show that example from our episode, and then I show the next example, and then I show the exact same scenario with a greater curve on, and you've got this fantastic seal, even though it's an irregular shaped tooth, and it lies up right where the contacts need to go. So just from the design alone, even if you didn't train with me, that is a big difference to a lot of people's work immediately, just from a design perspective. But of course, there are...
Well, objection number 1 would be then if you're not using a wedge, then how is it able to achieve the seal? Just to recap that, how is it able to achieve a seal? Because lots of matrix systems, they rely on the wedge to get the seal.
Sure. So, the best analogy, I think, is like a tourniquet. You know how a tourniquet works? Maybe that's too military. Maybe like, it's a bit gruesome, but like a noose. You know how a noose works, right? Oh my God. Yeah, I know, it's gruesome. But, it probably makes it very clear how it works. So imagine, the tooth is the poor soul, and then the noose is the matrix, right? And it just literally tightens around the neck super tight.
I got one for you that's a little bit more PG,
sure.
Yeah? How about we call it the floss ligature, how floss ligature works? It's dental as well. All right, sure. and that's a great example,
sure.
Right?
Sure.
You know how it goes more apical when you pull it.
Sure. Exactly that. It's like a floss. It's exactly like a floss tie, right? It's just made out of steel or brass. So that's how it works in regards to the seal. Yeah. So we're not relying on a wedge for that purpose. And so in getting the contact without a wedge, then we do a technique called contact opening, right? Which is the second most. Which is the first time you're blown away is a what? No wedge, and then the second time you almost collapse is
Contact opening, what did he say?
Sure.
So you got to explain this. Everyone just like, if you're chopping onions, stop. This is important. This is going to shock you. All right, go for it.
I mean, I'm just going to...
Big reveal.
Dentists are like me, right? They love the steps. I'll just paint the picture. You know, you've got this matrix in place. You've got the seal, lovely. It's lying up against the adjacent marginal ridges. You take your burnisher, you know, just under a rounded marginal ridge. In that upper third of the crown, you're going to burnish really firmly for 10, 20 seconds, you know, like a lot of people do. And then the difference is you will take a fine rugby burr, fast handpiece, no water. And with the belly of the burr, right, the belly of the burr, the max convexity, you're going to gently rub left and right on that spot where you just burnished. You rub it left and right, you take it off, you have a look again. You rub left and right, you take it off.
Water or no water? Because we're all thinking
no water because we need to see, right? And you continue to do that checking until you remove that final layer of matrix. And there you have it. You have this contact opening, a literal space in the matrix where you do not need the matrix if you want to get a contact. And when you do the technique correctly, the actual edges, the peripheries, actually got quite a nice bevel just from that side-to-side motion. As a result, if you see any of my videos when we're introducing floss in and out, it's super smooth, doesn't fray. It's pretty cool. Nonetheless, from that point, we want to make sure that that contact opening is super smooth. So when we run a probe from the greater curve metal, the brass or the steel, and then it goes onto the tooth and then goes onto the metal again, we want to make sure that that's seamless. We want a really nice seamless transition. And for obvious reasons, we want to remove this band, right? And then when it comes to removal, let's just keep it easy now. We've just done an MO, and people are probably thinking this because I was like, oh, hold on, aren't these teeth glued together, right? Actually, it's a super weak bond, you know, between this very small space, right? It's roughly 1 millimeter or 2 millimeters if it's a larger tooth in diameter, roughly. Take a flat plastic, twist, you separate that weakly bonded composite. And because it's so weakly bonded, it doesn't splinter or fray. You know, some of those objections may come to mind. They did for me. But yeah, I've been doing this since 2018. It doesn't splinter or fray. In fact, it's a super smooth transition. From that point, we take forceps, you know.
I mean, if you do this wrong, though, like, no, I'm just going to point out, if someone does it wrong, whereby they haven't done the burnishing, the burnishing step is really important with the instrument, because if you don't do that and see where you need to actually do the removal of the metal, and you don't appreciate it, then you might be actually too apical, and you might be actually poking a hole in the gingival embrasure space and not against the contact. And if you do that, then the composite it makes a mess. So you got to be a bit judicious, but you're right. Like the whole thing, like firstly, you got to convince yourself that what you're doing is correct. It's like when you do IPR the first time, that it feels dirty, it feels wrong. Like how dare you do IPR, right? Now, when you come to terms with, okay, I'm going to remove the metal and see the contact or the restoration next door, okay, and bond directly to that, except you're not actually adding etch or bond there, obviously, but like the composite's touching right against it, right? So that's like a paradigm shift. But when you're doing that, it is a great way to get a contact, and I can vouch for the fact that, yeah, it works, but you just got to train your mind. And also, the second person you need to convince, other than yourself, is your nurse. Literally, Zoe thought I lost my marbles the first time she saw me do this. Like, wait, what's he doing? Yeah. So you got to actually just give your nurse a pep talk.
Sure. 100%. And look, you know, there's two kinds of dentists I really encounter, right? There's going to be the dentist who says, give me the kit, I'm just going to figure it out, right? And that's cool. They can do it. And in fact, for them, I'd say, look, don't start off with the contact opening immediately. Instead, just get used to how the system works, how it all seats and do all that. And instead, just burnish and wedge as usual. Yeah, just at the beginning, right? Just use it as a regular matrix, no drama. Then there are other people who say, look, this makes a bunch of sense to me. You know, there's many benefits I see to this. You know, I really want to position myself as to be the guy who's really good at composites. And we could talk about why I think composites, I got a larger thesis at play here, is actually I think composites the future, really bigger picture for patients and dentists. And then those guys are the type of people who say, well, show me what you got, let me spend 6 weeks and let me just take the whole framework. Let me go from beginning, theoretical to, technique. I mean, for example, the way we break this down, we call it the BOSS method. So B is regarding, band on, and then O is for opening, whether you're doing a contact opening or an axis window. S is for seal, and then the next S is for snowplow. And so people are probably familiar with some of those things, but we spend time on each of those things so that you nail it and you don't waste time in practice making mistakes, right? You make mistakes with us on your hands-on day, and then you just get into the surgery and get going, right? Because nothing worse than faffing around with your patient looking at you, because they do detect it when when something's not going smoothly.
Well, I just want to make the contact opening technique a bit more tangible, because in case people are thinking, wait, is that what they said? Because they might have misunderstood. So you got the matrix band on, you got no wedge, you got a lovely tight seal. Literally, it's so nice and tight and it's good. There's no moisture, okay? Yep. The metal band is up against the adjacent tooth, right? So let's say if you're doing an MO on a first molar, you're up against the premolar. You're now going to get the rugby ball. Now, I do it a different way. I'll talk about it in a moment. Mahmood taught me this way. So you said with rugby ball, you remove, use like a yellow or red, a microfine one, right? And just gently sway around until you just perforate through the metal, and now you can see the restoration of the tooth adjacent. right? Obviously, before you've done this, you've burnished with a metal instrument, like a ball burnisher, to make sure you know where you're going. Now, Mahmood taught me, what's this technique called where you use the rose head and you use it in reverse?
Super burnish. I actually got that
Super
name
burnish.
from him.
I love this.
I actually got that name from him. So credit.
It's amazing.
Credit to Mahmood.
So shout out to Mahmood.
100%.
I love it. So I put the rose head, I think I put it about 15, 20,000, quite fast, but in reverse. So the cutting is very minimal. And it's just, I just see that thinning of the metal. And this is now my preferred way now of doing the contact opening. So you do that, and then when I've posted this on social media before, people message me saying, Jazz, won't your composite stick to the tooth next door? And what about the etching? Do you do the etching and bonding before you do this? Well, actually, no. Correct me if I'm doing it wrong as part of the protocols, but I do the washing. I do my etching and bonding after the contact opening. I'm just careful not to get the etch of the bond through the window, because the window is where the contact point is, and the apical cavity is way down there. So there's enough of a margin for you not to be cat-handed enough to get it in that window. Right?
Totally. But my point is there's tons of options, right? You can go the full hog and do the contact opening. You can just use it as a normal matrix and wedge as usual, or you can go halfway house and do super burnishing, which you can just thin the matrix out quite a lot without even doing the contact opening. I still recommend a wedge with that though, just so you get the same predictability. But the benefit of the contact opening is the predictability is just there. I can't remember redoing the contact.
Wait, you're saying use a wedge with the contact opening?
No, sorry. I'm saying if you're going to do the rose head technique, what you just mentioned, the super burnish, inverted commas. If you're going to do that, then I recommend still using a wedge just to apply some separating pressure if you're not going to make a contact opening with the rose head. So some will just thin it.
Oh, no. So, fine. So, fine. I understand. So, if you're not going to be brave enough to contact the adjacent tooth in your early stages, then to get a bit more separation from the wedge, not necessarily the seal, because you already have the seal, but just get more separation. Can you use a ring? Do people ever use a ring with a greater curve?
I've not really seen it. I don't do it. Denny never taught me to do that. So, I've never really seen it. And then I think actually it might interfere with the flare of the band.
I can just imagine it, it might mess up the flare, and then it might get like a convex, concave kind of thing going on around the edges. So, I have never done it either. Just a wonder.
What we're trying to teach as well is we're trying to teach, an approach for any dentist anywhere with whatever they have. So the common tools that dentists will have, we've give everybody what they need, but these are basic tools that everybody has, and they'll be able to do this, good dentistry. So the example of where that would probably get in the way is like, say you're doing like an MOD and a Class 5, and you're using a U-band, right? This guy's my favorite, by the way. And you could actually do this Class 5 and the MOD all in one go, but then putting a ring in a way, right? Another variable. But then we're going to have to teach when to use a ring, when not to use a ring. Just by not using a ring, it's not going to interfere with that setup. Does that make sense? So actually, just I just wouldn't recommend just even needing rings. It defeats the point. The whole point of this is simplicity. You
don't own a ring, yeah? You don't have a ring. You don't have a ring in your surgery.
There's no ring on it. No, there's no ring. I don't own a ring. In fact, what I'm going to do is actually, because I travel to different surgeries, right? I'm going to take a video of what's in my trolley, right? People are always curious to know what I work with, but it's pretty simple, pretty simple.
Just like a billion greater curve matrices.
Yeah, hundreds. So that's But then just so that we've completely made it tangible. Then you've twisted this bonded contact, inverted commas, again with this flat plastic is separated nice and cleanly, no problem. You take forceps close to the tooth as possible, parallel to the long axis of the tooth. You grab the band nice and close and you rotate, right? You're not going to pull it out, you're going to rotate. And by rotating, you'll feel how tight that contact is. And it will just move, dislodge, and then it just comes out, right? And so it's just, when you've got a great contact, because that's what happens. But here's another top tip for people who aren't using greater curve, because I've been this horrible situation when I was using Paladin sectionals. I remember this patient like it was yesterday. I was doing a lower 6 and 7. And very particular patient, knew about dentistry, which is always a red flag sometimes when the patient knows more about dentistry than I did, right? But came in, said about the problem, all the rest of it. I started doing it. And then when I finished this restoration, I was trying to remove this Paladin foil. And it's got the 3 little holes, the top tab, the little hole, and then on the sides. And I used the Paladin forceps and it ripped the hole because this contact was so tight. Right? Maybe I just over-condensed it, whatever else, or the matrix was really thin. And,
all that army strength.
Yeah, maybe. Let me not flex my biceps right now, Jazz. I've been training, I promise. But nonetheless, I pulled it, ripped the other side, ripped the top. I was like, what am I going to do here? And I literally had to drill the composite out to get the rest of that matrix out. So
yeah, I've been there, done that.
Awful. So here's the top tip for any, especially the young guys as well, young guys and gals who may have this problem. Don't stress. Always take a breather, right? They say these kind of adages in the army as well, that, calm is contagious. Like, stay calm, right? If you're not calm, the whole team gets affected. Your assistant does, the patient's looking at you going, why is there sweat dripping off his head? So always good to take a breather, stay calm. Try and take your flat plastic and really get in between the sectional foil and the composite as much as you can. So you're just trying to separate whatever bond there is. And then same deal, take a flat plastic, twist the tooth in between, just try and relieve whatever tight pressure there is in there, and then get that forceps nice and close, and again rotate it out rather than trying to pull it and shredding it to pieces, and that works really quite well as well. So
just to make it tangible, this is a bit like the sausage technique, not to do with implants, soft tissues or anything. The sausage technique was introduced to me by Lincoln Harris. It's when you're doing lower incisors and you're restoring wear on lower incisors, right? So let's say you want to do 1.5 millimeters of composite on the lower incisal edge, and you want to do all 4 lower incisors at once. Maybe they already have a contact, right? But you're going to put this big sausage of composite from lower incisor to lower incisor, so all 4 lower incisors, right? Then you just shape it, and you get like your thin instrument, your IPCL or whatever, and you get like the embrasures going, okay? And then you're going to get the shape right, and then you're going to cure it, so it's all connected together, okay? But because you thinned it out with the embrasure, you can go in your flat plastic and just twist, and cleave and break the composite apart. So I do like a good sausage technique.
Yeah.
Let's clarify. Have you heard of Bud Mopper?
no, I haven't.
Okay, this guy, I hope I'm saying his name right. We met him, me and Mahmood met him in Chicago recently. He's like a guru of composite in the States, Cosmodent. He teaches for Cosmodent, right? And so he had this, he called this technique the Mopper Popper.
Oh, I have heard of this. Yeah.
The Mopper Popper. So I shook this guy's hand, walk away, and Mahmood goes, Jazz, you know who that was, right? I'm like, who? Yeah, that was Bud Mopper. He goes, he's the inventor of the Mopper Popper. So the Mopper Popper, the Mopper Popper is basically just like you said. You get your flat plastic in and you just twist, and it just breaks those bonds. The Mopper Popper is what you should be using kind of when you're using the greater curve as well before you remove the matrix, just so to links back in again.
Sure.
The next few things I want to talk about in the interest of time is, before we do the whole communication bit, which is going to be off YouTube, one thing that I think is really important to get out there is the amalgam ban 2025. You probably know more about this than I do, and why I think if you're looking for a solution that's going to be applicable to dentists working in a system where, we're all time constrained, but sometimes we're delivering a service of getting our patients as healthy as possible, as quick as possible, then that's where the matrix does shine in a way. And I think with the amalgam ban, I think what your matrix offers is a solution that's like an alternative to amalgam that's not GIC. Like, you can still use composite, but you've now made it in a way that's very efficient. But you're going to do a better job of explaining that than I just did.
Yeah, I mean, so if somebody's just been doing amalgams for a whole bunch of time, and then they're faced with this uncertainty of, maybe I can't use this material I'm really good at, that can cause a lot of anxiety, right? And then what's the closest thing to that is GIC, just, pack it in a similar way, right? And for any of your patients listening to this, I say there's a massive difference between a filling, a metal filling, and a composite restoration. Me and Jazz, we've talked about this a lot of times. But, a filling is a hole, and, you're filling a pothole, with the metal. You can really do that. And I'm not saying there aren't very skillful dentists that can replace many, many cusps. They can certainly do that. But the skill and technique required to place composite is actually, I think, is quite different. The technical demands are there. There are prerequisites that are required in order for us to get a good bond and all the rest of it. Whereas amalgam is very forgiving. So GIC isn't, it just isn't an amalgam replacement. So for those people who are saying, okay, cool, there's a bunch of uncertainty, I do want to position myself to be able to do composites, learning how to use a greater curve system, learning the techniques that we teach and talk about, and talk with the whole efficiency aspect. And we've got delegates that are doing similar timeframes to amalgams. You can get very quick and very effective at working this way. It's very simple, it's very effective. As mentioned, it's the minimum number of steps to do a really good job. So, hopefully that addressed your point somewhat.
No, I think it's important to mention. I mean, whilst the number is shrinking year by year, it is something that gives some people a lot of anxiety, the fact that amalgam won't be around, right? Because they're so dependent on it. And so sometimes to have a way to be efficient in a world that's free of amalgam is important to consider, and will serve a group of dentists out there. We're now going to move this conversation. If you're on Spotify, carry on listening. Apple, yes, carry on listening. Okay, guys, hope you enjoyed the talk so far. If you want to continue this podcast where we talk more about the mindset, money mindset, sales, communication, and developing the confidence, all those non-clinical skills, then do head over to Protrusive Guidance, because that's where this continues. Otherwise, let's rejoin Sunny for the public version, and the outro is coming very soon. Tell us about the courses, tell us about where they are, what format they are, and how we can learn more from you.
Okay, cool. So, easy next steps for a lot of people. If they want to learn more, they could go on to drecomposite.com. So that's DREcomposite.com. And on there, you can click the free CPD tab, and you can literally book a Zoom with me. So you can put that with your team, or you can put that one-on-one. I just love sharing this stuff. So as mentioned, we go deep into techniques as well, and stuff that you can use immediately. So I want to give you some immediate wins. And then from there, you really get the full gist of what this is, and if it can help you, and if we're a right fit for you. But what I do know from doing this for 2 years, it's not for everybody, but the people it is for, I mean, it's a super good fit, right? So hopefully you'll be able to see that from like our reviews and testimonials and the people that we have helped so far. Secondly to that, to the dentists who just love gizmos and love gadgets and just want to get stuck in, they can also visit that same website and they can click shop Greater Curve, and they can actually buy a kit or certain bands that they want or the retainer. They can buy what they want. And then we've got a resources tab, and it just shows you how to set the matrix up and start using it. We're going to be uploading a whole bunch of interesting stuff for just people to get started who maybe don't want to do the course, which is perfectly fine too. Now, for those who do want to do the course, you can book it there. Mainly at the moment, we're doing them from London. So it is a blended program in that it's over 6 weeks, 20 hours CPD. So you do the online theory course first in your own time, bite-sized lectures. Then you turn up for the hands-on day. And when I say hands-on, you could see, I joke and I say today I'm going to be your drill sergeant because it's lots and lots of reps. Anyone who knows me, I'm all about the repetitions. It's just all hands-on, right? And so now, from the really good feedback from our delegates, like we've really remodeled this to really max it out. You know, every time a delegate tells me anything, we really just implement that, you know, no questions. So as an example, like we have breaks, but if you don't want to take breaks, you can just stay at a station and keep working away, and there will be trainers there to coach you through the day, you know, so we'll meet your energy completely. Then after that, we carry on for 6 weeks. We've got a private community group. We've got a knowledge base. We've got 5 webinars over that series. We begin with like the sort of Dre subgingival methodology, just that step-by-step, how do we approach it, troubleshooting common errors, just all the stuff you're really going to need to know after that phase. The one after that is sales, communication, and consent. You know, I'm a big fan of using tools like Chairside and Pearl. And so I actually show the exact workflows that I use. Like, this is how I do it. This is how I present it. PDF cheat sheets, you name it. Like, I really want people to win. So we do that. And then the webinars carry on, as you can see. And then the final one is like really advanced applications. And at that point, there'll be many delegates who are like, cool, man, this guy's giving me some lifelong skills. I'm back into the wilderness I go. And there will be others at that point who say, look, I want to do more training with you. And then we've got our anterior program, posterior. We have shadowing options. We have mentoring options. We have a longer term sort of coaching type of deal. You know, so we've got 2 of our trainers. They were delegates turned trainers, and they've been doing that program ever since they did the first course. So they've done all the courses plus this long-term coaching. And, you know, I'm not going to start talking the numbers now because I know it's public again, but some of the numbers that these guys are doing is eye-watering. And if anyone wants to know, just message me, say, you know, what was this guy doing before and what's he doing now? Yeah, as real life case studies from just the power of just being able to accelerate. You know, you're learning from other people's mistakes. I trialed and errored for a long time to find my feet. So we just package that really neatly into other offerings, including a sales program as well. So sales communication for the dentist. Yeah, hopefully that was not too much of a shield.
No, it's brilliant, because I'm not just saying this. I think when we have so many courses out there and choice, I think the reason why the Dre Composite course is good, having been on it myself, is if you are literally like a fresh graduate, right? I think you owe yourself a course like yours because it covers basic things like caries removal, right? Caries removal, subgingival, daily stressful scenarios that we have, and how to use this wonderful tool that you've imported from the US and now sharing throughout Europe and stuff. So that's great. But it's also in there for the experienced dentist who's had a go, tried all these matrices, and is now maybe their interest has peaked.
Totally.
And they want to go to the next level. They want to start doing black triangles with this kind of stuff as well. And they've seen some of the stuff you put out there. So I think there's something in it for everyone. But I would say, as a foundational thing, like if you haven't been to a good quality restorative course that covers these tricky scenarios, not the perfectly sized MO cavity that you never seem to get, the actual behemoth size ones I'm dealing with day in, day out, then I think do yourself a favor, check out everything they're doing at drecomposite.com, and I'll be sure to put that link in the show notes. So Sunny, my friend, thanks for talking wedgeless, amalgam bands, communication tips and pearls, talking fees, all that kind of stuff. Appreciate your time, bro.
I appreciate it, man. Thanks for having me. And big shout out to you as well, man. I really appreciate you. At the beginning, when nobody knew who I was, you was one of the first to say, look, jump on the pod, man. It's all good. I believe in what you're doing. So I appreciate that as well, man. Heartfelt.
Battle of the Matrix Bands. If you haven't seen that video, check it out.
Totally, man. Totally.
Well, there we have it, guys. Maybe you're going to consider now changing the way you use a matrix. Maybe you'll consider trying the Greater Curve. Or maybe you found another gem in there that you can apply on Monday morning. Either way, I hope you gained something from this podcast. This episode is eligible for CPD, so if you're on Protrusive guidance, scroll down, click on the quiz, answer a few questions, and if you get enough right, Marie, the CPD queen, will send you a certificate. I mean, you've come all this way to the outro, you deserve some CPD points. If you found this episode helpful, or you want to show a colleague about a different way of thinking and maybe shock them about the whole wedgeless and the contact opening, please consider sending it to a colleague. To how the podcast grows, after all. Thank you again for joining me, and to our guest, Dr. Sunny Sadana from DREcomposite.com. Oh, and of course, I want to thank my team, Erica, Chriselle, Gian, Marie, Nav, Emma, and Rakesh. You guys are always asking me, Jazz, how do you juggle everything? How do you get all these episodes out? How do you make so much content? Well, it's thanks to the team. And if you want to support what we do, please do consider joining a paid plan on Protrusive Guidance so we can continue to make all these videos for you. The website for that, once again, is protrusive.app. And I'll catch you same time, same place next week. Bye for now.